Hello, welcome to the study guide for National Dental Hygiene Board exam for the Community Health Public Health section. We're going to be going over many things here. First thing we want to understand is the FDI's definition of oral health is the oral health is a multifaceted and it includes the ability to speak, smile, smell, taste, touch, chew, swallow, and convey a range of emotions through facial expressions with confidence and without pain and discomfort. That also is very relative with what the definition of health is. So that was the definition of oral health. The definition of health is a state of complete physical, mental, and social well-being, not just the absence of disease or illness. Uh, Another important thing to remember is to understand the core functions of public health agencies at all levels of government. These are called the federal oral health initiatives or the core functions. The core functions are three-pronged. These are assessment, policy development, and assurance. So assessment meaning assessing and monitor the population's health and investigating and diagnosing. Policy development meaning the community is communicate and inform and create and utilize regulatory action. And assurance is basically enabling equitable access and to build a diverse workforce. Um, we're also going to get into um, what we need to know as far as levels of prevention. This should be fairly easy, as we know that there are three levels of prevention. There's primary, secondary, and tertiary. Um, when we think of primary, we want to think and we want to know, or we should know that the population we're providing primary levels of prevention to is that this population is healthy, meaning that there is no disease, there's no symptoms. Um, the goals are of primary prevention is to prevent disease from even occurring, and you'd be doing things like health promotion and education. And examples are of these are like dietary restrictions or skills or behaviors. Secondary level of prevention is when there is disease present, meaning that these are the early phases of disease. Sometimes they're asymptomatic. So the goal for this is to try to detect it early and try to return them back to health as soon as possible. So this could be like controlling risk factors or screenings. And essentially, this is early intervention. So this may include things like fluoride varnish on demineralized areas. You can also place fluoride in places that are not demineralized. That would be in primary. Same example goes for sealants. You can place sealants on a deep pit and fissure that does not have incipient decay. That would be primary. If it does have incipient decay on the occlusal pit, then it would be secondary, since we know that fluoride releasing sealants can arrest incipient decay. Third is the tertiary level of prevention. We know that this is when there is advanced disease status, meaning that there is loss of function, loss of tissue. Yes, the goal for this is to reduce the symptoms and the impact of existing disease, maximize the quality of life. And these can be people in the ICU, or it could be implants, bridges, and dentures. So it's like a rehabilitation of sorts to try to get them to a healthier state. So that's primary, secondary, and tertiary. The next thing we want to understand is what epidemiology is. It is the study of the cause and pattern of occurrence and the determinants of diseases. It's used in dental hygiene in the clinic and the community to describe normal biological processes, describe patterns of diseases, identify determinants of disease, test hypotheses, and evaluate healthcare systems and how care is provided. So, to prevent disease, you must know about the disease and how it occurs. Um, so, going back to primary, secondary, tertiary, if you were to be asked what level of prevention are Maria and John providing when educating pre-type 2 diabetes groups on food choices, that would be secondary. If you would have a question like what level of prevention are Maria and John providing when educating school children, that would be primary. And then if you were to be asked what level of prevention Maria and John are providing when working with ICU patients, that would be tertiary. Let's get into endemic, epidemic, and pandemic. Okay, endemic is basically like a normal occurrence of the presence of a disease in a population. So when you think endemic, it's like at the end of the day, you're not really worried because it kind of normally happens. So it is kind of expected, sort of like the seasonal influenza. So endemic is expected and it is predictable and it is in a population. When you think epidemic, you want to think that it is increasing. So it's large and an unexpected increase. Epidemic is unexpected increase in the number of cases. So epidemic, like epinephrine, you're increasing the heart rate, right? So there's an unexpected increase. Um, and then when you think pandemic, you want to think it's like an outbreak. It's a complete outbreak. It's gone geographically, crossing borders from continents, or it's starting to become almost global. So something cool to remember, this is endemic before epidemic before pandemic. Okay. The next thing we need to understand is mortality means the number of deaths. So when you think mortality, you think that a mortal can die. Okay. Morbidity, excuse me, is the rate of an illness in a population. Natality is the number of births. So mortality is the number of deaths. Morbidity is the rate of an illness. Natality is the number of live births. Okay. Um, One thing also to remember is the frequency rates. When you think of incidence, you want to think of new cases of disease in the population. So it's giving insight into the risk and probability of contracting the disease. So this is just new cases that are arriving. Um, and an example of that would be like counting cavities. Um, and so when you think of prevalence, you're not only taking the total number of new cases, you're also taking the number of existing cases, old cases in the disease. So that is prevalence. It gives insight into how widespread the disease is in the population. And also, um, morbidity is also used in prevalence. Using to determine prevalence rate, you need to know the morbidity as well. Um, so, so we're going to stay right there, kind of. We're going to get into the types of studies that there are. There are many different types of studies. There is retrospective, prospective, longitudinal, cross-sectional, control groups, treatment groups, and then there's the type of blindness. There's single blindness and double blindness. Um, what we're going to talk about here is that retrospective, meaning looking in the past, okay, for exposure and information. Prospective study is to look into the future. Longitudinal studies is a long period of time where we collect data like more than 2 times. A cross-sectional study is a single point in time. Each person is studied only once. A control group does not receive experimental treatment and provides the baseline to compare the treatment group results to. A treatment group is the group that receives the experimental treatment. And then blindness depends on who knows the treatment and the control group assignments. So single blindness means that a researcher remains uninformed and unaware of the identities of the treatment and the control groups. Double blindness means that both the researcher and the subjects are unaware of who is in charge of or who is getting the treatment and the control group. So in double blindness completely removes bias. Okay. Uh, let's get into independent variables and dependent variables. So independent variables are the experimental treatment option. So it is the controlled and it is manipulated by the researcher. Something that helped me remember uh, independent and dependent variables is going to be here. Where is that? So dependent variable is basically the change that you want to see. Okay. Um, Independent variable isn't going to change. So for example, if you were to if you are testing toothpaste and you want to see the whitening effects on a certain group of people or population, the independent variable is going to be the toothpaste, and the dependent variable is going to be the level of whitening that has been achieved. Um, One way that I know for sure um, how to remember this is that so the independent variable is what should cause the change in the dependent variable. So that is basically the dependent variable being the score or the thing you want to see change. So in my example was the dependent variable is if we want to see lower plaque scores or higher, whitening, or lower index or a higher index, you want to see a change in the indices. That is the dependent variable. The independent variable would be something like if in the research question, you're asking if, which mouthwash, uh, fluoridated or non or unfluoridated, will result in lower plaque scores. Well, then the independent variable would be the mouthwash. And the dependent variable would be the plaque score. All right. We'll get into more of this as we go along. Um, Another thing that we need to remember is sampling techniques. Sampling techniques are ways to come up with a manageable study population. These include randomized, stratified, systematic, judgment, convenience, snowball, and quota. Uh, what we need to understand is that randomized is each element of the population has an equal chance. So this is randomized is the best when you want to reduce bias. So an example would be is that you pick 6 candies from a bag with your eyes closed, and how many of each color, right? So that would be randomized. Again, randomized is to reduce bias, the best one to reduce bias. Stratified, on the other hand, is when you are dividing the population into groups based on characteristics. So it is the sample population by picking from each group. So you can put candies into groups based on color, and then you can pick one from each group, and then how many of each color. Okay. Um, And then systematic is like you're picking every X participant, every X number. So if you put candies into a long line, you're picking every fourth candy. That is a systematic approach to sampling techniques. Judgment, do you have a high chance of bias with judgment? Because basically it is when there is some familiarity with the population and you're using personal judgment. Uh, they use this when there's no worry about bias. You just need the right kind of people. So there's a high chance of bias there. Convenience is the easiest one. You just do the group chosen based on what's readily available. So whatever spilled on the floor, you pick the ones that are closest to you. How many did you get? And then I mentioned snowball and quota. Snowball would be to select a member of the population and ask them to refer more members, and the sample size keeps growing because more people are referring other people. And a quota is a predetermined number of participants. Once reach the size, no more participants are recruited. So it's like we want 10. Once we reach 10, we're good. Um, so that is sampling techniques. Okay, randomized is the best to reduce bias. Stratified is dividing the population into subgroups based on characteristics and selecting one from each group. Systematic, every fourth, every fifth, every 10th. Judgment is highest chance of bias. Uh, and familiarity. Convenience is um, not judgment, but mostly what's the easiest, what's the closest. All right. Um, then we need to understand the two categories of studies. There's descriptive studies and analytical studies. Descriptive studies describe like an epidemic with respect to a person, place, time. It's used with when minimal is known. There are no comparison groups in descriptive studies, and you use descriptive studies to generate a hypothesis. For analytical studies, you have observational and experimental studies. Um, you can test a hypothesis with analytical studies, and you use comparison groups. Again, there's two types of analytical studies, observational and experimental. Observational, researcher does not control what's exposed. Experimental is you start now having rules and conditions. Also, we need to know what a cohort study is. A cohort is, again, a group of people with similar characteristics. We'll get more into this as we move forward. And then there's case control studies, where we find groups of people with an illness and then compare to a group of people without the illness. Those are case controls. And then we compare prior exposures of the group. So control over the case control, right? Because it is known who has the disease to begin with and can control the cases. Um, let's get right into the next thing. We're going to talk about the epidemiological triangle. And we've talked about this in class before. The epidemiological triangle has to do with host, agent, and environmental. Host is who, agent is what, environment is where. Okay. Um, so host is who, so factors about the person, they could be their age, their sex, their behavior. Agent would be, it could be a biological, pathological, chemical, nutritional. Environment, where would be basically the outside factors. Where is it happening? Purpose for the epidemiological triangle is to visualize disease and contributing factors to identify how to prevent it. So again, you have host, agent, and environment. And that's how you determine risk factors, if they can be modifiable or non-modifiable. Next, we're going to talk about the chain of infection. Chain of infection, there's 6 links to this chain of infection, and we want to think of the mnemonic CREAMS, CREMES. So CREAM stands for causative agent, reservoir, exit portal, mode of transmission, entry portal, and then susceptible host. So the causative agent is described in an agent factor, right? So just like the epidemiological triangle, it is like it could be Streptococcus mutans or lactobacillus, right? Or some sort of pathological agent. Reservoir is where the agent lives, grows, and multiplies. So it could be the environment, it could be humans, it could be animals, it could be a babysitter with carries. Exit portal is where the agent leaves the reservoir. So it's either through the mouth or through the nose and sneezing. Um, I believe it could also be like defecation. So the M in the creams, mnemonic is mode of transmission, and that would be like direct contact with the spoon that someone was using. Basically, how the agent is carried from one place to another, and you have direct or indirect transmission. Direct would be droplets, spreads, um, or direct contact between susceptible hosts and the reservoir. Indirect would be airborne. It stays in the air for long periods of time, uh, or it can stay on inanimate objects, or it could be vector or animal, animate objects. Entry portal, where the agent enters a new host, could also be the mouth or the nose. And then the susceptible host, this could be like an infant. Okay, so creams, causative agent, reservoir, exit portal, mode of transmission, entry portal, and susceptible host. Uh, so from there, we're going to go into the social ecological model. And social ecological model involves intrapersonal, interpersonal, community, and societal. Intrapersonal is like an attitude or a belief. It is within the person and it shapes their behaviors. So intrapersonal examples could be like, I smoke because I thought it was cool, or I smoke because I cannot live without it. Interpersonal means that it is like a network that is between or influence between other individuals. So that involves peer pressure or influence from a parent. That could be an example of like my partner does not like when I smell of smoke, or my best friend always has cigarettes. The community level of influence, it's basically schools, workplaces, neighborhoods, uh, so institutional factors, public policy factors, community factors, that could be something like, I have to walk a block away from work to smoke per policy, or my health insurance gives me $50 rebate for each month I do not smoke. So that means that there are things in place that exist institutionally that prevent certain things from happening. Then there's the societal level of influence, and that's a broad, socially acceptable or social norms. That could be like, your actions could impact others, so you should be mindful, or freedom of choice and pursuit of happiness, no matter the cost. So things like that, these are just like sayings or that people put out there. So again, social ecological model, intrapersonal, interpersonal, community, societal. Um, we're going to now go into Maslow's hierarchy of needs. The mnemonic we're going to use for Maslow's hierarchy of needs is PS I love you. PS I love you starts with the base of the pyramid and goes to the top and ends kind of towards the middle at the top. So PS I love you. P stands for psychological needs. This is food, water, air, physiological needs, excuse me. Food, water, air, rest, things that your physiology needs in order to survive, right? Your basic needs. It includes your basic needs. So that's the P. The S is safety needs. So security, right? Having a roof over your head. Um, that's the S. Then the I is the top of the pyramid, which is self-actualization. So when you think of the I, you want to think like the I of on the pyramid on the dollar, right? The I is at the top. So that is self-actualization, self-fulfillment when you reach your full potential, right? Uh, and then L would be love and belongingness. So your needs for friendships and relationships. That's the L. And P.S. I love you. And then the U would be right under the I. It's kind of weird when I say that, but it's you. It is your self-esteem. Okay. That is your status, your respect. And that is right before you get to the very top. And I know it's a little weird, but if you think P.S. I love you, you're thinking physiological needs, safety needs, your self-actualization or self-fulfillment, then it's your love and your relationships, and then it is your self-esteem, you, your respect. Okay? So we want to reach the I. That is the goal. Get to the point where you are self-actualized and you're self-fulfilled. Um, but if you were to put it in the pyramid, starting from the base, it would be physiological needs, safety needs, love and belongingness, self-esteem, and then self-actualization at the very top. All right. Let's talk about the health belief model and some concepts for behavioral change. When we think of the health belief model, we want to think of perceived susceptibility, perceived severity. We want to think of perceived benefits, perceived barriers, cues to action, and self-efficacy. Self-efficacy is one of the key words when you're thinking about health belief model. It attempts to explain why people choose to change their behavior and to prevent disease based on what they believe about the disease and themselves. So, health belief model, it's perceived susceptibility, perceived severity, perceived beliefs, barriers, and perceived, um, and then cues to action and self-efficacy. Okay, and an example of this would be, for example, factors about the person. It could be health literacy, a demographic, and then it could be belief of a threat, determined by the beliefs, what their susceptibility is, uh, belief of the benefit, determined by what they think how it's gonna benefit, then belief in self-efficacy, and eventually it should lead to behavior choices and actions after cues to actions. Next, we're going to go to the trans-theoretical model, which is also called the stages of change. When you think of trans-theoretical model, you want to think of things like pre-contemplation, contemplation, preparation, action, maintenance, and they must achieve each step or they could relapse. So the trans-theoretical model assumes that changing behavior is a continuum of motivation, the motivational readiness for change. You don't just wake up one day a runner or a flosser, right? So again, you have pre-contemplation, which would be like someone who's not motivated and they're not thinking about changing in the next 6 months. So why would anyone want to be a runner? So we're thinking about jogging here, right? Or running. Someone in pre-contemplation is before even thinking about it, they're asking themselves, why would I want to even do that? Then the next level is contemplation. That's when they actually start really thinking about it even more about, being motivated and considering the change. So they could be asking themselves, like, seriously thinking about changing, but not quite ready yet. So I should probably start running for my health, but not soon. So that would be like someone taking the board exam. Yeah, I should study for the board exam. It's coming up, but they don't really do it. And then preparation is actually investing in motivation and deciding to change and is also actually getting ready for the change in the next 30 days. I am going to buy new running shoes and start in 2 weeks. That's like saying I am going to study for the National Board Dental Hygiene Board exam next week. Then action is they've actually started. They have already been running regularly for 3 weeks. I began changing, started within the last 6 months. That's where we're at right now with the dental board exam. We are taking action. The next step would be maintenance, is the changed behavior for more than 6 months. Chance of relapse is low, but not obsolete. So they could be like, I am a runner now. The change of me going back to the couch potato is low. Termination means that they've adopted the behavior and have absolutely no temptation to return to old behavior. This is a lifelong commitment. They can say, I love running, I do it on holidays. How can I apply this to the dental hygiene board exam? Is that we've been in dental hygiene school for 2 years. We're here. We've maintained a consistent level of academic studying, and now we're ready for the final pitch here, which is taking the licensing exam, and then we finally become dental hygienists, and then we don't have to study for the dental board exam anymore. Anyways, moving forward, we also want to think about what external motivation is, internal motivation is. External motivation is the reward from outside, like if your mom is going to make you happy. If whatever you're doing is you're doing it because it's going to make someone else happy. Internal motivation focuses on the reward from the inside, so doing it for yourself. This is pretty self-explanatory. So better results with learning when people are internally motivated and they tell themselves why it's important to them. Why do you value this? Is why I value it, because it's important to me, not important to what other people are going to think of me. So internal motivation obviously is the ultimate way, right? Um, let's talk about stages of learning theory, which is the also called the learning ladder. Here we're going to think of the mnemonic ugly apes sit in a hut, which stands for unawareness, awareness, self-interest, involvement, action, and habit. Ugly apes sit in a hut. Unawareness, which is the learner has incomplete or inaccurate information. Awareness is correct information now, but they lack personal meaning. Self-interest is the learner personalizes the information, realizes that there is a problem. Involvement is motivated to act, they become involved, and they desire more. Action is that they're actually testing their concepts. And then habit, meaning that the learner begins to experience gratification. So let's not confuse the stages of learning or the learning theory with the trans-theoretical model. They do sound a little similar in that they both have a step of action and habit. Habit would be in the stages of learning. You can kind of look at habit in trans-theoretical model as the maintenance phase. So they're kind of similar, but they're different. So when you think of trans-theoretical model, you're thinking of pre-contemplation, contemplation, preparation, action, maintenance, and then termination, meaning that they've adopted the behavior and there's no temptation to return to old behavior. That is in the trans-theoretical model. The stages of learning does not have termination. The stages of learning ends at habit. Ugly apes sit in a hut. Okay. Um, let's talk about now the dental hygiene process of care. All right, so we should be very familiar with this. This is basically ADPI. ADPI stands for assessment, diagnosis, plan, implement, evaluate. The dental hygiene process of care also includes documentation at the end of it because we need to document everything, right? So the process of health promotion program planning um, involves assessing, planning, implementing, and evaluating, and then documenting. Assessing is gathering the data about the population, could be primary or secondary data. Planning means to create the plan and to address the need, implement, to carry it out, evaluate to see how it worked. And then we might have to compare these between a patient and a community. If we are assessing the patient, we're doing an oral examination. If we are assessing the community, we're doing survey or data collection. When we are planning with the patient, we are doing treatment planning. When we are planning with the community, we are doing program planning. When we are implementing in the process of care with the patient, we are carrying out the treatment. We are doing the treatment on them that they need. It could be an SRP. When we are doing that when we are implementing with the community, we're actually commencing and participating in the program operation. So that could be screening, that could be applying fluoride, sealants, and then evaluating would be to see how they did. Um, with the dental practice, we see that the patient benefited from the SRP. They no longer have those etiological factors. For the community dental health, that would be evaluating or appraising the results. Like we got better education, better results, better indices. Well, if we were to do it again a second time at a school, compared to the last time, they have a lower caries index, for example. Um, the next thing we're going to go into is uh, we kind of already talked about it. Primary data is data that we collect ourselves. Secondary data is data that already exists, so like a census. Okay. Let's talk about the types of exams that exists. Types of exams that exist, there's type 1, type 2, type 3, type 4. Type 1 is the most complete type of exam. This literally can take place in a dental office. This is a complete comprehensive exam. There are complete sets of x-rays. There's lighting, study models, tests, instruments, mouth mirrors, everything. Everything's available in type 1. Type 2 examination is a limited exam, meaning that there is very limited amount of x-rays. There's very limited lighting source. Uh, there is lighting source, but usually it's just a mouth mirror in all instruments. But the key to the type 2 is that there's not many x-rays. Type 3 and 4, here we get into more like community type things because there are no radiographs available. These are screenings. Okay, these are not like exams anymore. And there are no x-rays. For type 3, there's a lighting source and there's a mouth mirror, maybe some instruments for type 3. Type 4 is literally there is no instruments. You literally just have a tongue depressor and a light, even if that available. You might not even have a light. You just have your eyes, gloves, and a tongue depressor to look. And of course, there's no radiographs. So type 1 is the best in competition for the confidence of a diagnosis. Um, one way we can remember this is check for radiographs. Type 1, yes. And type 2, yes. Type 3, no. Type 4, no. If 3 or 4, check if there's a mirror. Type 3, there's a mirror. Type 4, there is no mirror. Okay. Um, Now we're gonna get into some of these indices. Okay, so if we're gonna be thinking about measuring dental caries or cavities, we're going to be, and especially on permanent teeth or adult teeth, we're going to be using the capital DMFT or DMFS. DMFT stands for decayed, missing, and filled teeth. Usually they're permanent, 28 teeth, uppercase, fully grown teeth. DMFS is decayed, missing, filled, permanent surfaces. Usually this would be 28 teeth. Again, 128 surfaces, posterior 5 on 16 maxillary teeth, anterior 4 on 12 teeth maxillary. Decay is observable breakdown of enamel. Missing or needs extraction due to caries. So the M doesn't just mean that there's no tooth there. The M in missing could mean that there's so much cavity there that it looks hopeless. But you don't include the third molars or congenitally missing teeth. Filled slash restored due to caries. You don't include trauma or cosmetic alterations or a bridge abutment in those. You just include fillings. All right. Uh, to calculate that, you count the number of teeth or surfaces. Okay. For primary teeth is DEFT or DFT or DEFS or DFS. These are all lowercase. DEFT stands for decayed extraction is needed, restored primary teeth surfaces due to caries. Does not consider teeth that have been exfoliated naturally or have been came off naturally. Um, so the way you calculate this is you count the number of teeth or surfaces with DEF and combine the E for the need for extraction into decay category. There's also the root caries index. So these indices that we're talking about here are to determine caries. All right. DMFT capital, DEFT or DFT primary, and then root caries index, RCI, which is the attempts to assess the extent of root caries within the context of individuals. There's usually 4 surfaces possible: mesial, distal, facial, lingual. And you only count the cavitated lesions for that. Okay. So that's all for caries. Again, caries, DMFT, DEFT, and RCI, root caries index. If we want to talk about gingival conditions, okay, which we know is reversible, right? When you think gingival, think gingivitis, it's reversible. You want to think about the GBI, gingival bleeding index, the SBI, sulcus bleeding index, the GI, the gingival inflammation index. These indexes measure bleeding, okay? The GBI is gingival bleeding index, is the presence or absence of bleeding from intraproximal surfaces. For the GBI, you want to think of floss. When you floss the area, you evaluate if there's bleeding. That's when you count the number of sites on the facial or lingual area. SBI, you're going to be using a probe. A sulcus bleeding index measures the presence or absence of bleeding using a probe. And you observe 30 seconds and you count the number of sites. And the only way to get into a sulcus is with the probe. So that's how you're going to remember what they use for SBI. And then GI is gingival inflammation index. This measures the severity of inflammation based on color, consistency, and bleeding, i.e., by looking at the signs of inflammation. You can also use a probe for GI, and then you would add up the scores. 0, 1, 2, 3, 0 being normal, 3 being severe. All right, so that's measurements of gingival conditions. You use a floss for GBI, you use a probe for SBI and GI, gingival inflammation. The next set of indices are periodontal conditions, which are irreversible. So for indices, loss of clinical attachment is determined from the CEJ to the bottom of the sulcus, not the pocket depth. Okay, kind of knew that already. So for periodontal conditions, you want to think about these types of indices. You want to think about the PSR, which is the periodontal screening and recording. You want to think about the CPI, the Community Periodontal Index, which is where they use the WHO probe. Also, there's only 2 for periodontal conditions, is the PSR and the CPI, the periodontal screening and recording and the Community Periodontal Index. The PSR is a rapid assessment of periodontal health in all sextants. It requires a special probe. It could also include the WHO probe, yeah, which is the same for the Community Periodontal Index. Um, the CPI, again, is the Community Periodontal Index developed by who? And it's the first and second molars in each sextant. And then when you want to think of oral hygiene care, which is reversible, you have the OHI simplified, the biofilm index or plaque index, and the patient hygiene performance, and the VULP manhole index, VMI. Let's not get confused with some of these, such as the gingival inflammation indexes or the GBI, gingival bleeding index, or DMFT, because oral hygiene does include plaque and calculus. So for oral hygiene indices, we're thinking of OHIS, measures oral hygiene status for cleanliness, involves scores for debris, hard and soft debris. The biofilm index or plaque index, that's the one we do at school. So we know how that one goes. Um, then there's the PHP, Patient Hygiene Performance Index, assesses loosely attached material on teeth, biofilm materia alba. Um, and then there's the VULP Manhold Index, used to test agents for supragingival plaque to control calculus inhibition after a prophylaxis. So all those are indices. Now let's go into defining outcomes, um, such as Medicare and Medi-Cal. Let's talk about that. Medicare and Medi-Cal. Medicare was released in 1965. Health insurance for elderly. Medicare has an E at the end, so think of elderly at the end of Medicare, and the disabled as well. Medicaid is the health insurance for the poor, and they give aid to the poor. That in California, that's Medi-Cal. Okay. Um, One thing also that we want to understand are the scales and levels of measurements, and these include nominal, ordinal, interval, ratio, or noir. Noir is black in French, so do not black out trying to remember the order of the scales of measurement from lowest to highest. Most precise, so it would be from the easiest to the hardest. So when you think of nominal, you want to think of simple categories. They all have the same value. So it doesn't matter. It could be male, female, outside, inside, Asian, Hispanic. I mean, there's doesn't really mean that one is more important than the other. So they are basic and they're used in surveys for demographics. And the order does not matter. Blue, green, white could be one, two, three. Doesn't matter if it's three, two, four. Three is not better than one. That's nominal. Ordinal would be categorical. There is a rank. They have a rank, and usually it's more than two options. So it could be like levels of agreement. It could be disagree, neutral, agree. It could be poor, average, good. It could be gold, silver, bronze. So it's like, did it do well? No, not really. Yes. Those are ordinal. There is usually more than two options. So the order does matter, but the difference really doesn't. For interval, here now we get into the numerical quantitative. So nominal, ordinal are categorical and qualitative, and then interval and ratio are quantitative and numerical. So interval would be a credit score between 300 to 800, SAT scores 200 to 800. It could be Fahrenheit temperature. Spaces between are equal. The order does matter, but the zero is arbitrary. It's not a meaningful zero. Now, when you get to ratio, that is the most precise. There is an absolute zero, meaning that the zero means something. and it's the most sophisticated way of measuring things. So you have height, weight, length of time, zero, like a zero weight. You have a weight of zero. Well, that means that it's weightless, right? So the order also does matter. The order does matter. Um, let's now get into descriptive statistics. Here we're going to get into positively skewed, negatively skewed, the mean, the mode, the range, all that stuff. So for example, also we're going to get into grouped and ungrouped frequencies. So let's talk about the mean. The mean, okay, is the average of something. So meaning that you're going to add all the scores together and then you're going to divide by the number of scores. So if there's 10 different scores, you're going to add all of them up and then you're going to divide by 10. That's going to be your mean. Okay. Again, this is how how we're going to describe measures of central tendency. All right. So we can determine a frequency distribution on an XY axis. All right. Um, Also, like I mentioned before, grouped frequency distribution versus ungrouped frequencies, meaning like if you got a set of numbers, like 10 numbers, right? And then you have two of them are within the 70s. So you have 78 and 79, and then 81, 82, 83, 84. 78 and 79 are two within the 70s range. And you got like 81, 82, 82, and 86. You got four in the 80s range. And then you got 91, 91, 91, 96. You got four in the 90s range. Ungrouped frequencies would be it's like if there's just 78, there's only 178, 179, 181, but then there's 282s. Well, that's two, right? So anything that is standing by itself would be an ungrouped frequency. All right. Back to the mean. So the mean, you're thinking about the average. All right. When we're thinking about the median is the exact middle of it. So you're going to divide the data set into two equal parts. 50% of scores will be above 50% below, all right, or exactly in the middle. To calculate that, you'd place the scores in the data matrix, located in the middle, cross out the top or the bottom, and also, or if there's an even number of data points, you find the average to find the exact middle of those two middle ones. But if there's an odd, you'll find the middle one right away. The mode is the most frequently occurring number, right? So in a data set, whatever number is occurring the most, that is the mode. The highest grouped frequency, the highest ungrouped frequency would be the mode. Then there is something we need to understand is that there is a bell-shaped curve. If there's a bell-shaped curve, it is symmetrical. All right. When the data is plotted using a normal curve, meaning that the mean, the median, and the mode are all equal, that is a symmetrical distribution. However, when there is a positive skew and a negative skew, that's what we need to understand here. All right. For a positive skew, the tail goes to the right. And then for a negative skew, the tail goes to the left. So a good example for a positive skew would be like if you're going on a roller coaster backwards, right? So it's like you start from the deepest drop and you're going up and then you slowly do the tail. That's a positive skew. A negative skew would be like a normal roller coaster, like you're going up and then you're ready for the drop. Another way of explaining this is that the in order to understand this further, um, we have to know when the mean or the mode is greater than the median. And we'll get into that right now when we go over the review questions. Uh, but then we need to know the range as well. The range is the difference between the highest and the lowest score of data. So you get the two numbers and then you subtract from the highest and the lowest. Um, Next thing we need to understand is when it comes to inferential statistics, we need to know that validity is the degree that an instrument accurately measures a variable. Reliability means that something that is reproducible. So to the extent which the method of measurement performs consistently, you have intra-examiner reliability, or also known as intra-rater reliability. Within, right? Consistent measurement by the same examiner. So intra meaning one person, inter-examiner meaning consistent between examiners, right? Between more than one. Intra one, inter two. Calibration meaning that uh, it helps increase inter-examiner reliability. So if results show discrepancies in measurements or inter-rater reliability is low, then calibration can increase consistency, which increases reliability and validity. Um, Now we're going to talk about correlation coefficients. Here is we want to get to the either a positive one or a negative one. Um, so a positive correlation is +1. So if something is closest to the positive correlation, for a positive correlation, it would be 0.9. That would be the highest if that was the only option. If there was a 1.0, that would be great. But if there was a negative 0.9, that'll be the closest to the negative correlation. All right. So the perfect negative correlation is a -1. Also, we're going to talk about t-tests. You know that t-test means two scores. So when you think t, you think for two. There's statistical hypothesis used to test two mean scores. ANOVA of variance is when there are three. You are three or more mean scores. You're thinking of ANOVA. Then we want to know that a p-value of less than 0.05 is statistically significant. If it's greater than 0.05, it will negatively affect study results. So we want to make sure that an acceptable confidence interval limit is 95% or above. Anything lower than 95%, it's not confident enough to trust. 95% means wrong 5 times out of 10. All right. So that being going through, let's start with the review questions just to get a little bit more in depth of what we were talking about here. So here is the premise for one of the board questions. So Susie is a dental hygienist hired as a full-time health education specialist and in an elementary school with 20 pre-kinder to 5th grade classrooms. The demographic is low socioeconomical status. Before her employment, preventative oral hygiene education was not emphasized by the school administrators. Within 2 months, the dental hygienist, Susie, screened all the students and completed data that includes OHIS scores. Parents, teachers, and school nurses were interviewed as part of the assessment, and the following dataset indicates number of students in each classroom of the 30 students who have not seen a dentist in the last 6 months. So here we have different numbers. And it is from 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. So 20 different sets of numbers. Okay. The question number one is, what is the mean number of students in each class who have seen a dentist in the last 6 months? So again, when you think of the mean, you want to think of average. All right. Um, One way I remember this is average people are mean. Um, Horrible way of thinking about stuff, but that's how I remember it. Anyways, so you add all the numbers. This data set reached to 15.45. So you add all the numbers given and divide by 20. Then the calculator confirms that is 15.45. What is the median number of students who have not seen a dentist in the last 6 months? So here you're going to place all 20 numbers from smallest to largest. If it is an odd number, then the median is the middle number. But if the set is even, then what you have to do is you have to get the average of the two middle numbers. So in this set of 20, we have numbers ranging from 6 to 23. And since it's 20 and it's an even set, the middle numbers are 16 and 18. And so what we did is we added those two numbers and then divided. Is that what we did? Yes. Okay. Moving forward, what is the mode of the given data set? So the mode is the most common number that appears in the data set. There were five 20s. So 20 would be the mode. What is the shape of the frequency distribution of the curve for the given data set? So after evaluating everything, we got that the mean was 15.45, the median was 17, and the mode was 20. So the answer for this is that it was negatively skewed. Why? If the mean is less than the mode and the median, then it is negatively skewed. So remember, mean, people are average, right? It sucks, but it's helpful here. Okay, so the average, the mean, is 15.45. The median was 17, and the mode was 20. So the point of the rule here is if the mean is less than the mode, which it was, then it is negatively skewed. If the mean is greater than the mode in the medium, then it is positively skewed. But the mean was 15.45, the mode was 20, and the median was 17. So it's the lowest number. So this is a negatively skewed central tendency, meaning negatively skewed. It's like a normal roller coaster. Okay, going slowly up, the tail goes to the left, and then the drop down to the right. All right, Susie wants to determine the prevalence of caries in permanent teeth in the student population at the school. Which indices should she use? Obviously, capital DMFT. Capital letters mean permanent in adult teeth, and DMFT measure caries and decay on teeth. So 28 to be exact, which also does not include thirds, traumatized teeth, or treated surfaces. Okay, Susie is gathering data to learn more about the population. What phase of the program planning process is Susie currently in? So this is the ADPI. So she's in the assessment process. It's pretty obvious here. Gathering data about your target population happens before implementing and evaluating anything. So that is the assessment phase of ADPI. Susie decides she is going to plan an intervention focused on toothbrushing instructions. She decides to teach one of each grade classrooms using a Typodon model and one using YouTube videos. The data will be separated for each grade. Before and after the instruction, she will perform a plaque index. Which of the following is the dependent variable? So we spoke about this before. The dependent variable in this situation would be the plaque index score, because the plaque index score is what's being measured and is what is being observed. The dependent variable should change in response to the intervention, meaning that the independent variable would be toothbrushing instructions, either by YouTube or using a Typodon. Okay, next question is Susie's population choice is what type of sample of the elementary school population? Well, for her, it was stratified because she selected a sample from each grade group. So she put candies into groups based on color and she picked one from each group. Stratified. So here's another one. Plaque index is an example of what type of indices? This is an oral hygiene index when you think of plaque index. Plaque index or biofilm index, OHIS, patient hygiene performance, and VOLP method. Those are all part of measuring oral hygiene care, which is reversible. After a year of educating students, Susie notices that the students are excited and happy to talk about Susie about their brushing habits, and their plaque scores have reduced significantly due to incorporating daily brushing. The results of the study have a p-value of 0.3. Students are displaying characteristics of which stage of change? All right, so forget the p-value there. The fact that the students, I think it should have been 0.03 because if it was successful, because it wasn't by chance. The fact that the students are explaining to her how happy they are and excited, talk about their brushing habits, and the question is asking which characteristics, which stages of change is this? This is going to be the stages of learning or the learning ladder. The answer is habit. So think of ugly apes sit in a hut. Unawareness, awareness, self-interest, involvement, action, habit. Habit because I love this. Thank you so much. Look how much better I'm doing, right? So they're excited. What stage of change? You look at the options that are given on the test, and that'll kind of also tell you whether it's the health belief model, which is, as we know, perceived susceptibility, self-efficacy, all that stuff. If it was the trans-theoretical model of change, which would be contemplation, pre-contemplation, all the way up to termination. But here, one of the options were habits, and that is the H, the last stage in the stages of learning. Again, a p-value needs to be less than 0.05 to be statistically significant, meaning it did not happen by chance. So yes, I was correct in stating that. Again, the results of the study are statistically significant. So that was not a mistake. They did that on purpose, and that's false because we just talked about that. If it was really 0.3, they would not be statistically significant. Which of the following is the strongest correlation relationship, showing a direct relationship among the variables? So out of all the options, 0.7 was the strongest correlation. So a strong correlation relationship cannot be greater than 1 and cannot be a negative. So we'll kind of touch that on again, but 0.7 was the strongest out of the options there. So here we go with that. 0.7 was the best answer. So here's another question. The median for a bell curve is 24. What is the shape of the frequency distribution for the given data set? That's going to be a normal curve, right? So whenever we saw the word bell curve, right? So when you see the word bell, this is a normal distribution. The mean, median, and the mode should be the same, meaning that there is no skew and it's a normal curve. Question: Sean is monitoring the disease patterns for his community. While reviewing data, he notices that there is an unusual increase in the number of individuals testing positive for the influenza virus for this time of the year in his own community. This unusual increase in the number of cases is known as, the answer is epidemic. Epidemic because of the term unusual. Unusual or unexpected. You want to think of epi, raising, all right, in cases. Endemic means it's not unusual, meaning that it's a constant presence. It's at the end of the day, you're not really worried. But here, Sean is monitoring disease patterns where there is an unusual increase in his community. So that's an epidemic. Which sampling technique results in all potential participants having the same chance of being selected for inclusion? Well, the word same chance, or those two words right there, you want to think of randomized. Again, randomized meaning it eliminates bias. Systematic, meaning every X number. Judgment means when not worried about bias or selection is made from being familiar. Convenience is the easiest and readily available. Also, stratified. Um, we talked about that. Consistency between examiners is called intra-examiner reliability. Consistency can be increased through calibration exercises. So the first statement was false. So consistency between examiners is not intra-examiner, it's inter-examiner reliability. So the first statement was false because consistency between examiners is inter-examiner reliability. Intra-examiner reliability is consistent measurement and performance by the same examiner. Calibration helps increase inter-examiner reliability. The number of newly diagnosed dental caries is an example of an incidence rate. The number of filled decay and newly diagnosed dental caries is an example of prevalence rate. Both statements are true. Incidence is the number of new cases, risk or probability of getting disease, and prevalence is the number of old and new cases, the widespreadness of it. Remember, we use morbidity for prevalence. Which of the following is an example of internal motivation? And that would be for behavior change, that would be self-fulfillment. So the key word is internal, meaning personal value and why it's important to you. Internal motivation focuses on reward from with. External motivation focuses on reward from the outside, like making mom happy. Pat is treating a 6-year-old patient displaying signs of demineralization. To address the need in the assessment process, Pat decides to apply 5% fluoride varnish to the demineralized area. Pat is practicing what level of prevention? We know that this is secondary because demineralization already exists. Again, primary, no disease is present. Skills, health behavior, you can be vaccination, diet restriction, things like that. Secondary disease is present, and tertiary condition is in advanced. In the research question, which mouthwash, fluoridated or unfluoridated, will result in the lowest plaque score? Identify the independent variable. We know that the independent variable would be the mouthwash. The independent variable is what should cause the change. In the research question, does laser therapy or periodontal scaling and root planing reduce the most BOP? Identify the dependent variable. Again, we want to see a change in BOP, so BOP would be the dependent variable. Independent variable would be the laser or SRP. Once a community takes self-interest in the information being presented, what is the next stage of learning? Okay, so again, self-interest, that's ugly apes sit in a hut, the learning ladder. Unawareness, awareness, self-interest, involvement, action, habit. So the question was, once a community takes self-interest in information being presented, what is the next step? It is involvement. So after self-interest is involvement. Ugly apes sit in a hut. Unawareness, awareness, self-interest, involvement, action, habit. When assessing a population to prevent disease, identifying the appropriate level of Maslow's hierarchy of needs can provide the guidance for health education. Before educating on ways to fulfill the feeling of accomplishment and prestige, you should first work on the patient to establish belongingness and relationships. That is a false statement. The first thing to work on is physiological needs, then safety and security, before belongingness and relationships. And again, this is PS, I love you. Uh, Physiological safety, belongingness, esteem, and then self-fulfillment. So, but again, the base is PS, which is physiologically and safetyness. The I would be the I at the top of the pyramid, which is the self-fulfillment. Then the love you is belongingness and love, and then you is self-esteem. P.S. I love you. You are collecting primary clinical data on your population. The instruments you are using to collect data include probe, mirror, explorer, lights on your loops. You are completing what type of exam? So you are using the instruments you are using are probe, mirror, explorer, and the light on your loops, meaning that you have no x-rays. No x-rays, but you're also not using a tongue depressor. You're actually using, so we know from our previous conversation that that is type 3. This is a type 3 type of screening. Type 3 and 4 screenings have no x-rays, 4 being the most limited. With a tongue depressor, maybe a light. 3 has a light and the mirror, maybe an explorer probe. Type 1 is the most complete. Type 2 is a limited exam where you have some x-rays. You're collecting primary clinical data on your population. After taking an FMX, you work with the patient and bring them to the treatment area with the radiographs. You have a mirror, probe, explorer. What type of exam are you doing? Type 1. We know that because of the FMX. All right, last few questions here. Sure, Cher and Dion are collecting primary oral hygiene data using the Caries Index DMFT. They collected data from a ninth grade classroom. There was a total of 10 students who turned in the parental consent to participate in the study. The following DMFT scores were obtained: 1, 2, 5, 25, 2, 6, 3, 4, 5. So what is the range? The range is highest minus the lowest. So that is 5 minus 1. Hmm. No, that's not the highest. The highest number in that set was 20. The lowest was 1. So that's 20 minus 1. The range is 19. What is the mode? Again, the mode is what appears most often. The mode would be when we put that in order, we see that 5 appears 3 times. That's the most in all of them. So the mode is 5. The median, the median is the average of the two middle numbers since it is even. So that is the clarification we needed. The average of the two middle numbers if it is even. So it's 4 and 5 were the middle numbers. So 4 plus 5 equals 9. 9 divided by 2 is 4.5. So 4.5 is the median. um, what is the shape of the graph? First, you find the mean first. The mean is 53. Remember, average people are mean. So mean was 53. The mean is greater than the mode. The mode was 5. So this means it is positively skewed. So when the mean is greater, it's positively. When the mean is less than everything else, it's negatively skewed. What is the ungrouped frequency of 7? So 7 does not appear at all anywhere in this set of numbers. So it's 0. There's no frequency of 7 in this set, meaning that 7 was not even in this set of numbers. So it's 0. What is the grouped frequency using interval of 5? So here we separated these numbers. They're basically, when you put them in order, they're 1 through 20. But obviously it's not 1 through 20. It's like 1, 2, 2, 3, 4, 5, 5, 5, 6, 20. So we grouped 1 through 5, then 6 through 10, then 11 through 15, and then 16 through 20. There were 0 numbers in the 11 through 15 set. So when we grouped them using intervals of 5, it's asking what is the grouped frequency? What is the grouped frequency using inter for the second grouping? So the first grouping would be 1 through 5. There was 8 numbers between 1 through 5. The second grouping was 6 through 10. There was only 1 number. So the answer for that question would be second grouping frequency is 1, because there was only 1 number from 6 through 10, which was only number 6 in that data set. What is the cumulative frequency for 15? Well, 9. Example. A cumulative exam is everything you learned up to that point. So there are 9 numbers under 15 or less in the data set. So the question is, what is the cumulative frequency for 15? So how many numbers are under 15? Basically, the whole data set except for 20. There's 10 numbers in there. So the answer was 9. 9 because there are 9 numbers under 15. Don't let that question get you. So that's the end of this. We're going to pause. Just to clarify as well, when we were talking about the epidemiological triangle, the host, the agent, and the environment, all this is surrounding one important factor, which is time. The time characteristics for all this is like the incubation, the length of the disease process, and the trends and the cycles. Another thing that's important are the types of epidemiological studies. We know that we spoke about this before. There's experimental and non-experimental. All right. So when you think of experimental studies, okay, you know there needs to be some sort of randomization going on, a randomized controlled trial or something. If it's non-randomized, that means it's quasi-experimental, or it's like a community trial. But when we get into descriptive and analytic, that's going to be on the left side. So we were thinking about this framework that we're very familiar with. And you have the left and the right. The left would be observational, not experimental. Experimental, interventional would be on the right. So on the left, you have individual and population-based, which both have descriptive analytic studies. But the ones that have the cross-sectional and the case control and the cohorts, those are all individual-based analytic studies. All right. Population-based studies, you're going to be doing health surveys or ecological studies, descriptive versus analytic. Individual-based non-experimental studies on the analytic case would be cross-sectional case-controlled cohort. If there's case report or case series, that would be descriptive. So you're talking about specific cases. So that would be descriptive. And also we want to make sure that the way that we rank quality of evidence, the most critical information, it's almost like a pyramid again, but it's not Maslow's hierarchy of needs. Here we have where we have the most highest evidence that is the most important. It's going to be a meta-analysis. That is the top of the pyramid. A meta-analysis is basically the gold standard for showing that something is a legitimate phenomenon that is occurring. So, and we're talking about peer-reviewed studies here. So the highest would be a meta-analysis. Right under that would be systematic reviews. And then under that would be critically appraised topics. And then under that would be randomized controlled trials. So randomized controlled trials are the gold standard, but that is for experimental studies, right? But as far as something that is like at the top of the chain, that is as far as like the quality of the evidence, right, would be like critical appraisal. That would be a meta-analysis. All right. Also, understand what gray literature is. Confers proceedings and reports produced by government agencies, research institutes. So this is like the sources of literature. You have primary, secondary, gray, and tertiary. Tertiary would just be Wikipedia, dictionaries, almanacs, encyclopedias. And then gray would be coming from like a government agency, um, or organizations or public outlets, usually for a professional audiences, the .govs, .orgs. But primary would be like original information, first person accounts. Secondary is any published or unpublished work that describes, summarize what a primary source was. And we talked about AdPi. We want to talk about scientific method. No, we're not going to talk about that. But that is going to be it for this video. Also, who is the father of epidemiology? That's going to be John Snow. Thank you.